right now. I want to first, before I go ahead, thank Maninder and Josh by extension. He was doing a poster presentation on this as I was doing a follow-up rounds presentation on this, so a lot of overlap. The purposes of this is to make you think an extra step when you see that ST elevation, those ST elevations on your EKG before you send them to cath. So this is a real patient. I was there. I think some of us were there. A young guy comes in as a notification, clutching his chest. Basically, he collapsed while in the kitchen off a stool, and he's complaining of chest pain. And obviously, you get an EKG. This is EKG. You see ST elevations. You see reciprocal changes. Me heart was activated, right? And if you don't, not quite sure, his blood results came, and you see his elevated tropes, right? So everyone anchors on, when they see something like this, activate cath. Even cardiology says, we're going to activate cath, and you get a chest x-ray. But what about his history makes you want to give, makes you pause a little bit? His age, he's young, right? But he did have some cardiovascular history. He actually showed up to the ED a week before chest pain. He had some weird EKG changes, stayed for 2 sets, and he was really obese. So he did have some cardiovascular history, so people felt comfortable sending him to Mihar at the time. What else? Bella stool, remote history of some kind of trauma. And what else? Mental status change, sudden, and it's the suddenness, sudden collapse. All right? That usually doesn't happen with STEMI. Usually it's like, oh, I'm having chest pain. They don't just completely collapse off of stool and do themselves.
Really high blood pressure rather than really low.
Sure. This is his head CT.
Was he Brady also?
Well, this is what his vitals. Tachy, high blood pressure. So yeah, so there was a pause in a moment. They're like, he fell off a stool. Let's put him in the scanner before sending him to cath lab. And when they saw this, they canceled B heart. He didn't go to cath. He ended up going to the ICU, where he eventually expired. So, just to give you an idea, people with subarachnoid hemorrhages, up to 14% of them, and these are non-traumatic subarachnoid hemorrhages, people without a history of remote trauma, some kind of trauma, 14% have cardiac abnormalities, especially on autopsy. And the idea is that when you have a subarachnoid hemorrhage, the hypothalamus causes a catecholamine surge. And catecholamines are like cardiotoxic, kind of like cocaine or whatever. So basically, it acts on the autonomic nerve endings in the heart. The myocardium goes some kind of neurogenic shock, and then you have these warm motion abnormalities that show up on the EKG. They also there's ideas they could cause severe coronary vasoconstriction, and this leads to ischemic changes on the subendocardium of the left ventricle. And autopsies have shown of people with subarachnoid hemorrhages, these endocardial myocardial lesions, otherwise contraction band necrosis. These are uncontrolled cell death that are only unique to cardiac myocytes. So, cardiac vascular changes in people with subarachnoid hemorrhages, there is a link between the two. And not only do you see ST elevations, you get deep symmetric T wave inversions, ST depressions, QT prolongations, U waves, torsades, V-fib, V-tac. A lot of these EKG changes. All right. Elevated troponins and BNP also takes place with people with subarachnoid hemorrhages, and they're usually associated with impending shock. Things like pulmonary edema or profound hypotension requiring pressors. And the theory behind the pathophysiology is with the pulmonary edema, it's like a catecholamine surge causes this increased resistance all over your body, decreased left ventricular contractility, and there's alveolar capillary leakage. The hypotension, there's a bunch of theories why it can cause that, but it's usually profound enough to require pressors. And so the typical scenario in these kind of patients is that somebody here who has a STEMI goes to cath and ends up getting a clean cath, completely clean. All the coronary arteries are completely clean, and people are wondering why this person's having STEMI, and they eventually scan the patient and find out that they were bleeding in their head. So if you anchor on the STEMI, the problem is that when you send people to cath, you usually add on what? Heparin, Plavix, a lot of anticoagulation, right? And if the person's bleeding their head and you end up anticoagulating them further, you're just worsening everything. So next time when you have a STEMI, especially in comatose resuscitated patients, or any history of trauma, or anything regarding sudden collapse, to start thinking, is there a possibility this person could be having a subarachnoid hemorrhage? If so, scan the patient, all right? Because sudden collapse in STEMI is actually very, very rare. These are my references.